So it is 8 o'clock or possibly 8:01. So let's get started with comparative ocular path rounds. I am Megan Klimans, one of the staff pathologists, and we'll get right into the first case. Yes, we will. There we go. We get right into the first case. So this is a 4-year, 9-month-old spayed female Labrador Retriever. The clinical history for this patient is that there was an inflamed iris, an anterior chamber that was cloudy, and uveitis that progressed to glaucoma. The patient's intraocular pressure was 5 to 7 millimeter mercury, which is pretty low. That is a hypotonic eye. We have this gross image, though, that is rather curious. So on our hemisected view of the eye, we can see a cloudy cornea up here with that reddish haze at the periphery, whoops, which is peripheral vascularization. And we can see all of this weird kind of whitish, fluffy stuff carpeting the uveal surfaces, floating as strand-like material in the vitreal space. And it's even on the anterior iris surface as well, probably best seen on this side. So the iris itself is this pale brown leaflet here. And then everything in front of that is all this abnormal white tan tissue that's carpeting the iris. And there's also a little bit of vitreal hemorrhage visible down here. So let's now move to the histology. We'll find out if I set this up properly. F11, there we go. Let's see if we can get a good subcross going. Wait, we like the cornea to our left. So from low magnification, we can already see that there's too much purple on the surface of the uveal tract here. Lots and lots of cells. We kind of look around in this eye. We can also see little bits of purple here and there in the vitreal space. Let's take a closer look. Wait, that's going to put the cornea on the other side. So let's take a closer look at these cells that are carpeting the uveal surfaces. And when we do, it turns out that these cells are neoplastic. And they have a really interesting morphology to them. So here, for example, we can see that these cells are making rows along the surface of the uveal tract. Sometimes kind of a simple single layer row, and sometimes kind of a pseudostratified look almost. A lot of these cells have a narrow base and a rounded kind of club-like apex. And then they're often quite discohesive and they float off on their own into the intraocular chambers and kind of round up. And a lot of these cells, quite a few of them, have these large clear vacuoles in the cytoplasm that displace the cytoplasm and the nucleus to the periphery, which some may refer to as a signet ring morphology. So if you picture a ring with a big gemstone on top, which would be the nucleus, and the band, which would be this peripheral ring of cytoplasm pushed off to the side. That's why people will sometimes use that term. So lots of cells forming rows. If we track around the eye, we can even see them tracking to the lens, presumably climbing the zonular ligaments, which we can see kind of coming in and out of section here as these wispy eosinophilic strands, basically using the zonular ligaments as like a garden trellis. And we can see them climbing along the lens over here, still neoplastic cells forming a single layer. And we can see them invading the uveal stroma kind of multifocally. And when they do, they tend to form these little tiny lobules, maybe kind of cords that anastomose. And if we track back here, we can see the same cells forming these strands freely floating off into the vitreous. And way back here, even similar cells just kind of free floating as little islands in the vitreal space. The last thing that I'll show you is that way out here, on both sides really, but here in the bulbar conjunctival substantia propria, even outside the eye, kind of, or next to the eye. Even out here, the same cells infiltrating the tissue. So this is a neoplasm that has a fairly high degree of pleomorphism. As we were looking around, you probably spotted a good number of mitotic figures. There was a few. I can actually probably give you a specific number. There were 23 and 10 high magnification fields. And this neoplasm is showing an extensive carpeting of intraocular surfaces and kind of a multifocal distribution in that there's these random foci out here in the conjunctiva, as well as the populations inside the eye. And this pattern of distribution is highly suggestive of a neoplasm metastatic to the eye from another site. The other thing is that this morphology of cells isn't really consistent with anything that tends to form as a neoplasm inside the eye from local tissues, which is also helpful to make a diagnosis. And in particular, because it's forming these rows and layers and little tiny lobules, it's most consistent with an epithelial neoplasm in this case. So the most likely diagnosis, or most fitting in this case, would be a metastatic carcinoma to the eye. The signet ring morphology is common to a couple of different types of carcinomas that may occur in various sites around the body. It implies that these cells are secreting something, maybe mucin, hard to be sure just based on H&E alone. But the laundry list of potential primary locations that could produce cells with this sort of morphology is still pretty long. We could think of respiratory tumors, urothelial, gastrointestinal, et cetera, et cetera. So in this case, the recommendation for this patient is full staging and a hunt for a primary neoplasm because we assume that these cells did not arise locally. Unfortunate for such a young animal, only around 5 years, a little less than 5 years old. The other reason why I thought this case would be nice and instructive, despite, in addition to how kind of interesting the morphology of the cells are, is that this case presented clinically as a uveitis case. So a brief discussion on things that can kind of masquerade as uveitis clinically, but aren't uveitis when we do the histology. So some of the things that clinicians might use to determine a diagnosis of uveitis might be, for example, aqueous or cell flare, so cloudiness in the anterior chamber, which is exactly what they said in the history of this patient. But in this case, probably that cloudiness was produced in large part by floating neoplastic cells, or cell flare might have been produced by that. There was also the low intraocular pressure, which is often associated with uveitis, but low intraocular pressure is caused by anything that reduces the amount of aqueous production by the ciliary body or increases the rate of loss of aqueous. So you have like a rupture and some is leaking out essentially. And so in this case, probably the destruction of the ciliary body by the neoplastic cells was more likely the cause of hypotonia. And then, of course, another confounding factor is that there is inflammation around these neoplastic cells. Here's lymphocytes and plasma cells. So there is also a uveitis in this eye, as well as neoplasia, which is probably part of the reason why it presented as uveitis clinically. So just some interesting thoughts. The neoplastic cell is probably easier to see on this side, actually. For what it's worth, also provoked the creation of fibrovascular membranes and synechia, which is something else that might clinically, if you have like a rubeosis iridis or something like that, you might think uveitis, but there could be something else going on. So an interesting case that we can learn from, and that's all I have for this guy. If there aren't any questions, I have a lot to say about the next case, so I'll go to the next one. Okay, this is a really cool
Ryan,
case. Oh yeah, go ahead.
Ryan here on the comments online said we could send him some additional unstained slides for some IHC if you want, and he suggested also urothelial nature as a possibility.
Yeah, that sort of way that they have the kind of umbrella shapes in some of those areas. Yeah, I wouldn't be surprised.
So we might take you up on that, right?
Yeah, yeah. And for what it's worth, we don't have any more follow-up on this patient. Don't know what happened to this patient after this diagnosis. Not a good diagnosis, unfortunately. All right, so this is a 2-year, 8-month-old neutered male Alaskan malamute. So this case has an interesting history. I'll give you all the history up front. So this patient was enucleated for a history of chronic anterior uveitis. It was just uveitis in this case, so no surprises on the histology. The patient had ocular hypertension documented, but glaucoma wasn't confirmed. The patient has heterochromia iridis and a progressive thickening of, in particular, the dorsotemporal pigmented part of the iris, which is a very interesting piece of history for this case. So we'll go to the gross photo really quick before we continue with the history. From the front view here, as well as from the side view, you can see this heterochromia iridis. So heterochromia can present as two differently colored eyes, and it can also present as an iris in the same eye that has differently colored segments. And so in this case, this eye is oriented how it would be in the patient, and we have a left eye, and we have a dorsotemporal brown section of the iris and a ventromedial blue section of the iris. And you can see the same thing on the hemisected view. And so the thickening of specifically the brown part of the iris is interesting. And this thickening was progressing despite the use of high-dose topical and oral steroids. This patient was on immunosuppressive levels of steroids, but the condition was still progressing. And then they did a very extensive and thorough uveitis workup on this case. So this list reads like a laundry list of pretty much all the infectious causes you can imagine for uveitis in a dog eye to some extent. So toxoplasma, leptospirosis, all the fungal guys, histoplasma, blastomycosis, aspergillosis, and coccidioidomycosis, or almost all the fungal guys. Also Rocky Mountain spotted fever, Lyme, and Ehrlichia. And so the patient tested negative for all of these to some extent. At least not on the list, admittedly, so not an exhaustive list necessarily, but a very extensive one. I just want to point out how extensive it is. I guess Cryptococcus wasn't necessarily on that list either, although probably more common in the eye of a cat, but we had a very extensive negative infectious disease workup. So let's look at this case with all that history in mind. So apart from the heterochromia iridis and maybe a little bit of cloudiness in the cornea, which is probably part post-fixation artifact and maybe a little bit of something in the cornea pre-existing, there isn't really much to say about the gross view of this eye. Grossly, at least the lens vitreous retina, there's some probably post-fixation wrinkling of the retina, that's all there is, was all normal. And it's hard to see in side view to some extent, but the optic nerve was also listed as normal by the gross examiner for this case. So not much else to see on the gross view. Now let's take a look at the histology. So if it seems like I'm ignoring important things, trust me, there's a method to my madness.
Usually I sit next to you and ruin everything, but I'm keeping my mouth shut.
I've learned not to chime in too
I
early.
haven't learned yet.
Megan likes the
Well,
suspense.
I like suspense. And the thing is, I also do frequently ignore the elephant in the room, not on purpose, so, and could use a good reminding. So hence the caveat. So I'm going to take you on a tour around this eye, and we're going to start with the iris leaflet on this side. So if we look at this iris leaflet, we can see that there is a nice layer of pigmented cells on the anterior surface of the iris, as well as large numbers of dendritic to spindle melanin-laden cells in the stroma. And then on the back of the iris, this pigmented epithelial layer. So this is a posterior pigmented iris epithelium. So we have stromal melanocytes, we have a posterior pigmented iris epithelium. This is a brown iris leaflet, histologic presentation of a brown iris. If we go from there and track to the back of the eye. We go right towards the center. And there is something that is of note at this level in terms of lesions, but we'll get back to that, I promise. So at this level, we're gonna nudge ourselves away from that fold. At this level, we can see that there is a layer of retinal pigment epithelial cells here that is non-pigmented. So this is the dorsal fundus or the dorsal choroid. We don't really see much of a tapetum, but sometimes it can be quite thin in dogs. The choroid stroma at this level also has a few stromal melanocytes here. So kind of these spindle-shaped cells that are laden with melanin. So it's a brown choroid. So keep that in mind. Now, as we walk ourselves across the optic nerve, excuse me for the bouncing around. Now on this side, actually we're gonna nudge ourselves away from the fold again. We have the retinal pigment epithelial layer that is pigmented. And so now we're in the ventral fundus. And then also note how the choroid here, apart from these abnormal cells that are here, doesn't have as many stromal melanocytes as the other sides. This is a fairly hypopigmented choroid. And as we track along this choroid, we can see that. Because there are maybe some melanocytes here and there, but there we go. Quite thin and not a lot of stromal melanocytes to it. Very interesting. And then if we go all the way back up to the anterior uvea, this iris leaflet has no pigmented cells along the anterior surface. It has very few melanin-laden cells in the stroma. We'll talk about these guys that are here in a second. And it does still have a posterior pigmented iris epithelium on the back. So no stromal melanocytes, but a posterior pigmented iris epithelium is what we would expect for a blue iris. So it all checks out. We have a dorsal pigmented iris leaflet and a ventral blue iris leaflet, just like we saw in this patient grossly. So our heterochromia iridis. And what I thought was interesting as well is that the pigmentation of the choroid on each side kind of matched the pigmentation of the iris. Pretty neat. So now let's discuss the elephants in the room, now that we've had our tour around this eye and oriented ourselves. There are pigmented cells in the iris stroma of this blue iris leaflet, which maybe you can kind of have like a green iris sometimes, and maybe there's a couple of cells, but these guys are actually round and laden with melanin. And so these guys are actually more likely melanin-laden macrophages rather than stromal melanocytes, and that's interesting. The other thing to note in this iris is that, especially maybe if we scooch up just a little, there are a few lymphocytes and plasma cells around. So we have maybe a plasma cell there, maybe a lymphocyte there. So there's a little bit of inflammation, lymphoplasmacytic, in this iris leaflet, as well as a few melanin-laden macrophages scattered here and there. The other thing to note before we move from this iris leaflet is that the iris pigmented epithelium on the back here is sort of multifocally absent. So we see it here, then it's gone, then it's back again. So that's interesting. Now let's walk ourselves back to the fundus. I'm going to come out more to mid-fundus or so here and find the fields that I want. Nope, that's definitely not what I wanted. Wait for it. Maybe here is okay. So we already were seeing it while I was touring you around the eye, but there's definitely lymphocytes and plasma cells in the choroid stroma as well. And in some of these areas, you may imagine that some of these cells are a little bit rounded, the ones that are laden with melanin. And so there's likely a couple of melanin-laden macrophages in the choroid stroma as well. So what we have is a lymphoplasmacytic panuveitis, kind of mild in this case, pretty low profile, which is associated with a few melanin-laden macrophages. So interesting. Now let's walk back up here for some cleanup stuff. And for that cleanup stuff, note that we have this membrane extending from the iris leaflets onto the posterior iris and anterior lens. There's a little bit of artifactual attachment, but ultimately these iris leaflets were fused to the anterior lens. We've got posterior synechia. And if we walk ourselves to the back of the lens, there is posterior migration of the lens epithelium. We shouldn't see lens epithelial cells back here. And there's a little bit of hypertrophy and hyperplasia as well. So this is one of the earliest presentations of cataract that we get histologically, just migration of the lens epithelium posteriorly. We call this posterior subcapsular cataract histologically. It's really mild, really early cataract. And the reason why it's interesting to look at cataract in a case like this, lens-induced uveitis could be a cause of lymphoplasmacytic uveitis. So we want to see the severity of the cataract relative to the severity and extent of the uveitis and kind of compare them. And that can be worthwhile to try and figure out a case. So in this case, a pretty mild uveitis, also a pretty early cataract, and maybe debatable if the extent of the uveitis matches the cataract. But let's discuss this uveitis more. So we said that lens-induced uveitis could produce lens-induced uveitis could present as a lymphoplasmacytic uveitis, and it can. But pretty much a lot of other things can present as lymphoplasmacytic uveitis. So reflex uveitis associated with corneal disease could present as lymphoplasmacytic. Any of our number of tick-borne diseases can present as lymphoplasmacytic uveitis. It's an extremely non-specific finding in the eye. The melanin-laden macrophages are a little bit more interesting. In this case, clinically, they had differentials of autoimmune disease, as well as neoplasia, as well as other. It could be something else that they haven't yet thought of. And so autoimmune disease, thinking of that and thinking of melanin-laden macrophages, you might think of Uveodermatologic syndrome or VKH-like disease of dogs. So Voigt-Koyanagi-Harada, or VKH, is a condition in humans that causes eye, skin, and meningeal manifestations. In dogs, it's eye and skin and not really meningeal. So it's kind of similar, but maybe not the same. And you can call it VKH-like or Uveodermatologic syndrome, or UDS for short. And it is common in Arctic breeds. Remember, this patient is an Alaskan Malamute. And it is an autoimmune condition that is thought to target melanin. It represents an autoimmune condition that targets melanin, although it's not confirmed that that is specifically pathogenesis. Definitely autoimmune, suspected that it targets melanin. This is interesting. In this case, we have a heterochromic eye, partially blue, partially brown, with an extremely mild uveitis and some melanin-laden macrophages. And we can think of UDS, but melanin-laden macrophages aren't specific to UDS. So anytime that you have disruption of the iridociliary epithelium, necrosis of the uvea, anything that might release melanin into the eye, you could get macrophages coming in and phagocytosing that. So melanin-laden macrophages are not specific for uveodermatologic syndrome, not diagnostic for it. And if you had this case completely out of context, no signalment, no history, it would be very difficult to make a specific diagnosis with just this. However, we do have the history and the context. And I thought that this would be a good case to talk about atypical presentations of some of our classic diseases. So let's take a moment and think about what the quote unquote classic or typical presentation of UDS is. If I'm going to, and I am, suggest that this is an atypical presentation of UDS, or a relatively unusually mild presentation. So uveodermatologic syndrome typically presents bilateral and symmetrical in our patients. And it usually presents as a very severe panuveitis. And I've pulled a case really quick here to show you for comparison. This is what we would expect to make a slam dunk diagnosis, quote unquote. So here's a patient that has a panuveitis. If we take our tour around the whole eye, it's the entire uveal tract. That inflammation essentially bleeds into surrounding structures, a little bit into the limbal sclera, a little bit into the tissue around the optic nerve, very severe. The retina is still inflamed, but relatively spared compared to the uvea at least. And if we take a look at the character of this inflammation, it's a lot of macrophages, many of which are laden with melanin, lots of lymphocytes and plasma cells, and in this case, a good number of neutrophils as well. The uvea was overtly necrotic in a lot of areas, and probably those neutrophils are responding to that. And this patient was a bilateral enucleation case. And you might think that I'm showing you the same slide again, but I'm not. This is the other eye. And it looks basically just the same. So this is the typical or kind of classic presentation of uveodermatologic syndrome in our eyes. Tends to be bilaterally symmetrical, severe, and have these histological features. Whereas this patient has an apparently normal other eye and a very mild presentation that kind of approaches more of a non-specific presentation out of context. However, there's a couple of reasons why this presentation may have been kind of atypical in this patient. And one of them may be that there's less pigment in this eye. So it's partially blue. And we do have experience suggesting that blue-eyed patients have a milder presentation of uveodermatologic syndrome. And in fact, I've pulled this 6-year-old spayed female Siberian husky eye to show that off. So ignore the fact that there's a giant corneal perforation. We're just going to skate right over that. This patient had documented uveodermatologic syndrome. There was also depigmentation of the nasal planum. So we know that this patient had uveodermatologic syndrome. We have some history to back us up again. And the inflammation is relatively milder than our classic case, but one of the most striking features of this case is that if we look on the back of the iris and in the ciliary body, so sometimes the pigmented epithelium at the posterior iris is basically just absent. But in other areas, it's still there. You can make out this layer of cuboidal cells, but there's no pigment in any of these cells. And even in a blue-eyed patient, we should have pigment in that posterior pigmented iris epithelium. And I think this presentation is most striking for this case back here in the ciliary body. Look at that. There's 2 distinct layers of ciliary body epithelium, like there should be, but the innermost layer should be pigmented and the outermost layer non-pigmented. But in this case, they're now both the non-pigmented layer of the ciliary body epithelium. So this is an interesting presentation that we sometimes see in blue eyes, a milder inflammation. and either loss and or depigmentation of the iridociliary epithelium, and sometimes not as many melanin-laden macrophages in the uveal stroma itself.
Yeah, so that's a good reminder Megan's giving us, that blue-eyed dogs are not albino dogs, so they do have melanin. So the iris and ciliary body pigmented epithelium and the RPE cells, regardless of the color of the iris, regardless of the degree of pigmentation in these dogs, they always be pigmented. Unless you got a real albino animal like albino rabbits, where then you would not have pigmentation. So that is an excellent point as a reminder, and an excellent feature of these severe cases.
Yeah.
Great case.
So that's one of the reasons why it may have been presented milder. And then the other reason is that this patient was on immunosuppressive doses of steroids. So steroid use may change the numbers and types of inflammatory cells that we see in our histologic sections. That's worth keeping in mind. Keep in mind that the therapies that the patient is on may change things for you. This patient also has more stuff, but I've already gone on long enough, so I'll kind of briefly touch on this. And then also, I guess one more thing about UVDS, a reminder that sometimes our histology needs backup from the clinical features of the case, which in this case, the features of the case all taken together are most suggestive, coupled with our histologic findings. So here in this iridocorneal angle, especially since we have some other cases further down the line, I won't spend too much time. So we have an artifact of detachment Descemet's membrane here, but where the end of Descemet's membrane is, it's kind of a tapered thin end that directly contacts iris-like tissue, this thick band of iris-like tissue that's crossing the angle, kind of thicker than what we would expect for just a major pectinate ligament. There are discrete or distinct minor pectinate ligaments behind that, though, which is interesting. And this case also has some other weird features, though. For the angular aqueous plexus, we would expect it to be coming out at the level of the iris base, kind of here. But instead, we have vessels of angular aqueous plexus way back here. And then we also have scleral venous plexus, which it's easy to overinterpret the size of the scleral venous plexus, so be cautious about that. But it's relatively small diameter vessels, kind of smaller than I might expect. They look a little wimpy. So there's some interesting features here that almost are suggestive of anterior segment dysgenesis in this case. But this patient is 2 years, 8 months old, and the duration of disease was only listed as 3 months. So the patient only developed ocular disease as an adult. So probably the more appropriate diagnosis for this case would be goniodegenesis or some degree of pectinate ligament dysplasia going on in this patient. However, this malformation may mean very little to the patient prognostically. Ultimately, the diagnosis of uveodermatologic syndrome or presumptive diagnosis of UDS is probably more concerning for the remaining eye than any degree of malformation in the angle, because this patient didn't develop glaucoma associated with this malformation. And also because this patient has potential reasons for secondary causes of that spike in IOP in the posterior synechia. So if it's an uncomplicated primary glaucoma case, we know that the other eye will probably develop glaucoma within a set time frame, and we can push that out with prophylactic therapy. In a case like this where glaucoma was never really confirmed, take my word for it, it's less prognostically useful, or at least more questionable prognostic value. I guess the last thing that I forgot to mention, although I've already been going on long enough about this really interesting case, is that the remaining eye is blue. And that might be a reason why the other eye presented with an even milder presentation, or hasn't really developed obvious signs yet than this heterochromic eye.
Yeah, so regarding that, there's some interesting comments here. So Karen Naranjo asked the same thing, if the other eye was affected or not. So there's no history of uveitis on the other eye, right?
At least no history of, yep.
Yeah, so
at present, it would seem normal.
And then Billy said the same thing, that maybe if the other eye is fully blue, not heterochromic, that the inflammation might not be as impressive.
And it is, which is very interesting.
Yeah, it was funny because you were saying that, and the parallel conversation was happening at the same time with the same conclusions here. So I hope you guys are happy with the answers there. And then Billy also asked if there were, she said, was there any meningitis near the optic nerve? Not necessarily on your case, right? Yeah,
no, not really.
We see that inflammation around the optic nerve, and I think I usually interpret that as a continuation of the choroiditis in the pigmented portion of the choroid that extends around the optic nerve head, without a lot of more meninges or optic nerve. I think I wouldn't call that meningitis. And I know Bill is asking that because meningitis is a feature of Vokoyanagi-Harada syndrome in humans, or VKH in humans, which we haven't proved that in dogs, I think.
Yeah, may not be quite the same thing.
Not yet.
Not yet. So, all right.
Cool.
Okay. This next case will probably be fairly quick. I don't have a gross photo because the globe was not that exciting. Grossly. So this is a 3-year-old golden doodle, spayed female. The history we got was posterior synechia. And, oh wait, sorry, hold on. So sorry, the eye was enucleated because there was concern for an ocular, a uveal mass. They said a mass was noted on the iris that obscured the majority of the pupil. No menace present, no changes to conjunctiva or lids, unable to perform fundic exam due to small pupil size remaining. So they enucleated for concern of an intraocular mass. We received the globe and we did not see a mass grossly when we hemisected it. We said that there was posterior synechia, and because of the concern for a mass that we did not otherwise see grossly, we trimmed in a whole bunch of tissue at the beginning of the processing to try to make sure that we didn't miss something. Also, there was a pretty rockin' cataract present when we hemisected it. So clinically speaking, I got this picture after the fact because the clinician called and was concerned that we in fact did not identify a mass in the eye. So what we can see here is, here's the pupil. So it is present and it's quite tiny. And there's definitely something somewhat opaque behind it. So that's probably an indication that we're seeing a cataract through that very small pupil. So we have a miotic pupil. And also, interestingly, there's this sort of grayish discoloration of the peripheral iris. And I personally, I look at this and think, is that peripheral iris or is that like peripheral cornea? I can't really tell. But keep in mind, we did not have this photograph when we received the eye. So let's go look at the histo. All right. So the subgross is actually pretty boring. All right. So what we can see, cornea is off to the left.
How old is it again? I'm sorry.
3 years, 5 months.
Thanks.
Cornea off to the left, optic nerve is back here. Here's the lens. The lens is irregularly shaped and a little bit, the lens material is irregular as well. So there's our cataract. And then we have iris. We did not quite sample the pupil in this plane of section. We have this really darkly, the periphery of the iris is very dark at both sides of the eye there. The back is looking relatively normal. So there was no sign of glaucoma that we could see. And that darkly pigmented iris is not quite present here. And in this section, we have the ciliary cleft is open. Whereas here, it looks a little bit more collapsed. And here it's a little bit open as well, maybe artifactually. So let's just go ahead and jump in to the higher mag aspects of this eye. So no mass effect seen grossly, no evidence of neoplasia seen histologically, particularly at this point. What we do have is this very darkly pigmented peripheral iris, and there's this bright pink, very sort of solid layer of stuff on the surface of the iris there. As we come across here, there is this wispy membrane right here on the back of the iris, close to the pupil, which is probably that causing that posterior synechia, which means that the pupil wouldn't be quite as responsive if it was firmly adhered to the lens capsule. And we have a similar situation over here where we have a very darkly pigmented iris stroma, and we have this dark pink band of stuff on the peripheral iris. The lens fibers are degenerating, and here's some accumulation of mineral. The center of the lens, or the nucleus, is also affected in addition to the cortex or the periphery of the lens. And so this is Rocken cataract. So hypermature, probably cataract. As we move back here, the retina and the optic nerve look normal. So there is no evidence of glaucoma histologically, and they did not report glaucoma. So let's go ahead and get a little bit higher mag here. So just going to show you. Here's Descemet's membrane in its normal place on the back of the cornea. So we have Descemet's membrane, which is the basement membrane of the corneal endothelium, which is technically an epithelium, but we call it an endothelium. It's a little bit of a misnomer. So Descemet's membrane comes right down and arborizes slightly and contacts this iris tissue. And this space here is artifact. But when we move a little bit posterior, we see a very nice ciliary cleft with beams of the trabecular meshwork that then lead off into the actual aqueous humor outflow tract. So as Megan pointed out earlier, here's the vessel of the angular aqueous plexus, so aqueous humor flows out this and joins up into the scleral venous plexus, which then ends in the venous system. And that is how the intraocular pressure is maintained in an eye. So when we go a little bit more centrally, we look and see that this material is actually also basement membrane, or Descemet's membrane. And we have this nice layer of endothelium on the surface. So we have this sort of layer of basement membrane material with what looks like endothelial cells that are that's essentially displaced because it's on the front of the iris and it should not be there. I don't really know what to say about the heavy iris pigmentation other than it seems to correspond to these areas that has this phenomenon. So this is what we would call descemetization of the anterior iris surface, when Descemet's membrane and the corneal endothelium continue around the iridocorneal angle and carpet the anterior iris surface. This is an unusually thick layer of Descemet's membrane in this case. I don't really know what to make of it.
It's thicker than the original, right?
Yeah, it is. It's bizarre. I don't know. This is the weirdest case. I probably should have showed it to everybody when I got it, but I didn't. So I had a prolonged conversation. Oh, and so I can show you the rest of the eye that we cut. So this is a repeatable thing in pretty much every single section that we made, except that extra slice in the original slide. It didn't seem to be present there, but there it is here. And here is the best example of where it really continues right around. It is continuous. There is no ciliary cleft or opening of the ciliary cleft. So I was actually really surprised that this eye was not glaucomatous, especially given the tiny pupil and the posterior synechia. Anyway, so as we zoom around to look at these extra sections, it's very repeatable. So this was the most unique finding of this entire case, in addition to perhaps the advanced cataract. So I had a long conversation with the clinician who was concerned that she had enucleated an eye for a tumor in which we did not find a tumor. So I didn't know what else to tell her about that. She was a general practitioner. I believe she had consulted with an ophthalmologist on the phone who basically told her if there's concern for a tumor, the eye should be removed. So if ocular ultrasound had been used, she may have been able to tell that there was not any thickening of the iris leaflets, that there was no mass in the posterior segment, but I don't know if she had those capabilities. So this is just an interesting case. I think she said the eye had no menace. So the eye was blind, probably because of the combination of the cataract, the meiosis, the posterior synechia. And I personally think it would have gone on to become glaucomatous and painful given this malformation or this desmetization of the iridocorneal angle and the cataract, which no doubt probably would have led to more of a lens-induced uveitis. So anyway, just sort of an interesting case. There we go. So I personally think this was some form of anterior segment dysgenesis that included extensive desmetization of the peripheral anterior iris surface, causing peripheral anterior synechia, and a hypermature cataract that I thought was probably or possibly congenital or juvenile. So no glaucoma yet, but I told her that I was pretty sure it would have gone on to develop glaucoma. I'm not sure if the other eye is affected or not. I can't remember if what she said about the other eye. So if we go back to the clinical photo, once again, I think that gray discoloration here was probably the desmetization of the anterior iris surface. It could have also been maybe a little bit of, well, anyway, yeah, let's just leave it at that. So anyway, just sort of an interesting case. Oops, going the wrong direction. So kind of weird. And that's an unusual form of what I think is anterior segment dysgenesis. So there we go. Okay, moving on. This one probably won't take quite as long. This is an eye from a 6-year-old German Shepherd. The history we received was suspect trauma to the eye. The way they worded this made me laugh. So they said suspect trauma to the eye from specialist ultrasound. So I was picturing like a specialist like beating this eye with the ultrasound probe. I don't think that's what they actually meant.
Yeah.
But anyway, they said enlarged globe, chemosis, and glaucoma. This was also a staff pet. So the good news is that I don't think this was trauma induced by an ultrasound probe wielded by a specialist. When we hemisected the eye, which we thought was ophthalmic, the cornea is up at the top here. It's a little bit cloudy, so there's probably some corneal edema. The anterior chamber is not visible in this, so we have anterior chamber collapse. There is hemorrhage in what is now the posterior chamber, the vitreal space, and a little bit in the subretinal space. Here's the detached retina. Here's the lens, and what we have is this very obvious off-white linear foreign body that is in the eye. So this was lodged somewhere up here in the eye, so closer to the ciliary body or anterior segment. And so as you can imagine, as this eye was embedded with this cut side down and sectioned from there, this relatively impressive linear foreign body would only be sampled in a tiny bit here. However, I think Megan grossed this one and she cut the cap off this globe, which we always do when we are processing eyes, and then submitted an extra section of the cap because some part of this thing was in the cap. So I will actually start with the whole globe. And I think I was very quickly reviewing cases in my flat to decide if I needed deepers or special stains or anything. And I just didn't really pay much attention to this case at all until I really sat down to write everything. And I was like, oh, well then. Here is the cornea. And oh, I could go, let's do that. That's more fun and exciting. So cornea is to the left. Oh gosh. Cornea. There's hemorrhage in the posterior chamber. Here's the lens. More hemorrhage in the posterior chamber. The retina is detached. And actually, the only area that foreign body is sampled is right there. So I didn't see this on my initial pass through this case, my very brief review. So the anterior chamber is very narrow. The way the iris leaflet comes forward and then bows backward is very suggestive of iris Bombay, where we have at least somewhat focal posterior synechia of the iris to the lens. And then in this case, we have hemorrhage building up behind it and also aqueous humor, which causes the iris to be pushed forward. So it sort of billows forward. So that's iris Bombay. when we go and look at this, there it is. So I totally did not see this when I was reviewing the case very quickly, and went back to it afterwards when I finally looked at the gross photo, and I was like, oh, look at that. So we have this sort of multi-chambered kind of refractile object. This is plant material. So there we go. And then when we look at the extra section that Megan very cleverly trimmed in. So this is sort of a perpendicular section. So there's peripheral cornea, there's our iris, our posterior chamber, and then we have this surrounded by all the inflammation.
Much better.
So this is much more consistent, or typical, not consistent, much more typical of what it looks like when we find plant material in the eye. So it is very antigenic. There is often, these plant objects often come with their own flora and fauna of fungus and bacteria and all that stuff. This one actually looks relatively clean, but you can see it is surrounded by neutrophils. So this is consistent with plant material. Probably this is a grass awn that migrated through tissues and sadly ended up in the eye. However, I went home after writing this case and I was lying in bed and I was thinking, man, that thing was huge. Did I misdiagnose this as a plant material and this was actually a porcupine quill? So I actually pulled it out the next day and showed it to everyone, because once again, I didn't show it to anyone when I did it the first time. And we all agreed that we do think this is plant material. However, it is huge. So most grass awns are not quite this big. What do you think, Gasper?
Yeah, it doesn't look like a porcupine quill.
Yeah, like histologically, it looks like plant material. Maybe this is a thorn or something like that. We said we didn't really see the barbs on the outside of it that we often see with grass awns. And yeah, like most.
Cactus quill. We
Oh.
talk about like a cactus.
Oh,
You have
yeah.
a cross section of it. The cactus quills are organized in a real specific way.
Not except for what was in the middle of that vitriol space.
They tend to be a little rounder, right? The
Yeah,
cactus
they're-
ones. Yeah.
And then they're made of like, the cell walls are like tubular,
Right.
elongated.
Wait for it. This is as much of a cross section as I
Oh.
have.
That's some cool ones here. Thorn from a tree, like a hawthorn, maybe.
Okay.
Yeah.
Dr. D votes for a thorn.
It
Okay.
doesn't,
Dr. D is our plant pathologist.
not a pine needle. Yeah, no, that doesn't look like a cactus one.
Okay. Anyway, so a particularly large example of a grass awn, or maybe a thorn of some sort. Anyway, yeah, so I could sleep better that night after I like thought like, oh my gosh, did I just misdiagnose this thing? So okay, now Leandro has a few minutes.
Okay. Got time for at least one interesting case. Let me get it up there. That's yours, yes. All right. This one is, let me get a history here. We have a 18-year-old, never mind, got the wrong one. 12-year-old, not as old. 12-year-old Maine neutered Shih Tzu dog. And let me see here. The history is very extensive, and I will try to summarize. The problem is, well, there's lots going on here. We will talk about the history later, because otherwise it will give away too quick. It was enucleated because of mainly glaucoma, and they suspect a complete retinal detachment and vitreal degeneration. The interesting thing when we cut this eye open, you can see the image looks a little weird, right? You have all these linear streaks going across, almost like we cut through a paraffin embedded tissue already. But this is not. This is exactly what it looks like. This is not an, well, what we're seeing here is the reflection of the light from the light source. But these are real. This was a very, very dense gelatinous type vitreous. And that's why we're seeing all these streaks. It's basically when we cut through it with the blade, it created those waves. So imagine if you're touching this, it's almost like jello-like in consistency, right? And you can obviously see the detached retina kind of frozen in the middle of that gelatinous vitreous in the back. Have the lens, the iris. There's a little bit of it in the anterior chamber, but not that much. So let me show you what this looks like histologically, especially on subros. So keep in mind that super gelatinous material, when we got the slide, the first thing that I noticed, well, the first thing that I noticed was the slide, because I haven't checked the image right away. And then I realized, oh, there's a gross image. Let me take a look at it. So all that gelatinous material is visualized here as this hypereosinophilic proteinaceous stuff in the background. So all these cracks, again, these are all artifacts, but they were caused by during processing of the tissue that proteinaceous exudate was so dense that during processing it contracted and kind of cracked. That's why it is separated from the choroid and it kind of separated from the lens here. So imagine that normally this was filling the whole thing. But it was so dense and so proteinaceous that it sort of congealed and separated from the rest, and you can see these cracks here. So the cracks here are all artifact, but they go along with the gross image that we were seeing. So let's go back to the eye. The anterior segment of the globe was not informed of what was going on in the back. Looks relatively normal, maybe a little shallower. It's kind of hard to tell, but there's really not much going on with the cornea, with the iris. Everything looks fine. There's a thin fibrovascular membranes that extends on the anterior surface of the lens and causes a focal posterior synechia at that area right there, but really not much. Everything, the business is here in the back. So let's find the optic nerve. So here's the optic nerve, hypercellular, so there's gliosis. The optic nerve had, so it doesn't look cupped, but at the same time, there's retinal detachment. So every time the retina detaches, it kind of pulls everything forward. So it's a little harder to define cupping of the optic nerve. If we follow the lamina cribosa, which are these extensions of the choroid or / the sclera here, it's a little bit folded backwards. It should be at the same level as the choroid and the sclera. You know, if you turn your imaginoscope on, it can make the case that it's a little bit backward going, but it's not that impressive. Here's the retina, extensively detached, as we've seen, right? It's let me go one lower so we can actually appreciate. So this portion of the retina connected to the optic nerve head, and it kind of opens up forward, what we call a morning glory retinal detachment, as in the flower morning glory, right? And you can see that proteinaceous exudate both in the subretinal space, and it's kind of semantics now, right? Because the vitreous is in front of the retina. If everything is collapsed and the retina is plastered against the lens, then the vitreous is just that right there, right? Everything else is subretinal space. But it got that proteinaceous exudate. So let's take a quick look at the retina. So the retina doesn't look super healthy either. Oh, this is also cute. I forgot about that. There is some asteroid hyalosis, some asteroid bodies. The asteroid bodies in this case are embedded in that super dense exudate. They're a little more basophilic than we often see, but that's what they are right there. So let's just follow the detached retina. So here's recognizable retina. there's definitely retinal atrophy. The photoreceptors are completely atrophied. We know the photoreceptors receive oxygen and nutrition from the choroid capillary. So when there's retinal detachment, all of a sudden they're deprived of that oxygen and those cells atrophy. So here's the inner nuclear layer. Well, a little bit of the photoreceptors, the inner nuclear layer, and the ganglion cells are also gone. So there's variable degrees of both inner and outer retina. But retina is still recognizable at this stage. When we keep moving, you can see some of that exudation blending in with the retina itself, and all of a sudden it goes kaput, right? So basically retina, and all of a sudden we got red blood cells, and the retinal morphology is gone. There's some pigmented RPE cells that kind of detach together. So there's a focal area of a retinal hemorrhage and necrosis. So not only we have retinal detachment and atrophy, but we do have active necrosis. If you look here and there, you find some retinal vessels that are very interesting looking, like this fella right here. Bunch of RPE cells around. And so here is the lumen of this vessel, or artist formerly known as the lumen of this vessel. We can see some endothelial cells, and the wall is markedly expanded by that same proteinaceous exudate. So there's some degree of periretinal exudation and retinal, perivascular exudation and vascular necrosis. You can see similar stuff here and there, right? So this is starting to look like something vascular / hematologic / bleeding proteinaceous problem, right? Here's another vessel right there. So not a lot of inflammation anywhere in this eye. The main thing is this humongous exudation, tissue necrosis, and retinal hemorrhage causing retinal detachment. If we go back around the optic nerve and we take a look at some of those choroidal vessels, you can see how thick they are also. So there's some hypertrophy of the of the vascular endothelium with mild constriction of the lumen. Another thing I would like to point at, we have this exudate right here, right, in the vitreous. And then if you look at the larger vessels in the choroid or peripapillary vessels, you see the same type of exudate inside the vessels. And you can see how it's basically separating the red blood cells kind of in clumps right here. So we have the same exudation or the same densely proteinaceous material, both free in the ocular chambers, but also inside vessels, right? So it looks like something hematologic. The main things that we're seeing here is retinal detachment, tear, necrosis, hemorrhage, and the hidden history. There's a lot of it, but let's cut to the chase. Blah, 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 blah. Suspect retinal detachment associated with hypertensive retinopathy. They are concerned for neoplasia, given the medical history below, which we're going to get to it. But the owners didn't want to do anything, so they've enucleated. The history below is that the dog presented with chronic hypercalcemia with elevated ionized calcium, elevated total protein, markedly elevated total protein, more than 13. It has a biclonal gammopathy, most consistent with a systemic neoplastic process. Potential bronchointerstitial pattern on the thoracic radiographs. And what else? Again, elevated total protein, elevated globulins. So what they are describing here, and also the other eye, which is also very interesting, had multiple intraretinal hemorrhages and focal areas of low-lying retinal detachment. So whatever is happening here, it started happening in the other eye, which also suggests something systemic. So with the history of hyperproteinemia and biclonal gammopathy, and this very dense, very dense proteinaceous exudation throughout the eye that we see also inside the vessels, that is classic or strongly suggestive of what we call hyperviscosity syndrome, right? So hyperviscosity syndrome, and increasing the protein contents of the blood, cause it to be kind of a sluggish sort of, denser blood. There's a higher tendency for coagulation, a decreased vascular perfusion throughout the tissues. And what we're seeing here, the decreased vascular perfusion caused the hemorrhage and necrosis, and then it starts bleeding, but there's so much protein that protein exudates inside the globe and kind of congeals, causing the retinal detachment, etc. The main causes of it in dogs are systemic tumors, especially multiple myelomas or some B-cell lymphomas, but there are also some infectious organisms or some infectious processes that can cause specifically gammopathies that can cause hyperviscosity syndrome. They were already suspecting hypertensive retinopathy, which the vessels that we've seen, they kind of look thicker, but hypertensive retinopathy or chororetinopathy does not explain that exudation. So it's more likely that something systemic, like a tumor. We haven't got any follow-up. I asked for any additional information that they've received. The only thing they call is that there were some cutaneous lesions and the biopsy was not conclusive, but suggested a dermal lymphoma. So there's that. We haven't received confirmation of that. So here's a good example of hyperviscosity syndrome, which should lead the clinician to look for something systemic that's causing that. And we are 2 minutes past 9. So we're going to leave it at that. Thanks for coming. Thanks for joining us online. And we'll see you guys in a couple weeks.
Thank you.